Welcome to the Heart of It All. If you've been with us since the beginning, you know this is a podcast all about caregiving. For the Alzheimer's Awareness Month of January, we are focusing on the disease that is affecting millions of folks and their families. Today, we are joined by geriatrician Dr. Amina Jabbar. Let's get into it. Hi there, I'm Teri Hart, and thanks for finding us wherever you're listening or watching this podcast. One of the most compelling points in today's episode is Dr. Amina Jabbar reminding us to make the most out of our time, whatever time we have. For many, the choice to do that is a financial one. The Capital Direct Flexi Line turns your home equity into flexible support so you can arrange the care your family deserves now and pay it back when the time is right. Explore the options at capitaldirect.ca. January is Alzheimer's Awareness Month, and there is so much to be aware of. There are huge advancements in diagnosis and knowledge about what we can do preventatively, as CEO of Alzheimer's Society of Ontario, Kathy Barrick, told us last week. This week, we are so very lucky to have Dr. Amina Jabbar with us. Dr. Jabbar is a geriatrician in the GTA. She's also a health policy PhD candidate at McMaster University. Her work is focused on equity and geriatric health policy, models of care, and assessing qualities of care. Dr. Jabbar, thank you so much for being here.
Thank you for having me. I'm very excited.
So let's start with, what is a geriatrician?
Nobody ever knows. I don't think I knew what a geriatrician was until I got into medical school. The thing that I always say to people is, do you know what a pediatrician is? Most people know what a pediatrician is. People will say it's a doctor for kids. I say I'm on the other end of the spectrum. I'm a doctor for older adults.
I send out for guests a Google form and you actually put geriatrician brackets, doctor for older adults. Why don't people know this? Why don't people understand that there's a specialty doctor for us as we are in our senior years?
You know, uh, Partly I think it's because there's not that many of us, right? Like I think the last time I had saw numbers, there's something like 400 geriatricians across all of Canada. That's it. There's not that many of us. 200 of us are in Ontario. So, I think that's probably part of it is that, we're already talking about how hard it is for people to access family doctors. It's even harder to get a hold of a geriatrician.
Okay, well, thank you for being a geriatrician because I think it is a crucial part of medicine. And we are different as we age, right?
100%. I don't think people appreciate how much things just change in general for everything, every aspect of our life, our brains, our hearts, our kidneys, our livers. Nobody really thinks about those things. So it's nice to have, for me, to really be subspecialized in thinking about those things all the time.
So, is it a specific age that people should be looking for a referral to a geriatrician, or is it an event? Something happens?
That's a great question. The way I would often describe it is that your family doctor, if you're lucky enough to have one, is going to be the gatekeeper for all your specialists. They're going to be the ones who kind of figure out, do you need a cardiologist? Do you need a kidney doctor? Do you need all these people? They're also the ones kind of figuring out if you need a geriatrician. So the way I would think about it is a family doctor, they are such special humans because they know a little bit about everything. But the thing they don't have is time, right? You go in, you get 15 to 20 minutes max if you're lucky with your family physician. And when you're older, things are more complex. You need more time to think about things. And so, generally speaking, what we say to family physicians is if you feel like you're getting out of your depth, if there's something that you're missing about your older patient, there's something that's wrong that you can't quite put your finger on, send them to a geriatrician. Because my first assessment with a person is 90 minutes long. It's amazing. I get 90 minutes. That's one of the reasons I went into geriatrics. Every one of my initial consultations with a patient is 90 minutes long. It means I can sit down and actually talk to people about where they came from. What do their lives look like? They've usually lived 80 something years before they get to me. Where did you go? What did you enjoy? What did you do? And then kind of dig into the whole what are your health issues? What are your medications? Do a full review. It's not something a family physician has time to do.
And I think it's so crucial in terms of that trust factor between doctor and patient. You're spending the time to get to know somebody before you're asking them to tell you the most intimate details of their body and their mind.
Totally. Absolutely. That's 100% the case.
You said something to me in our chat before this interview, which I loved so much, Dr. Jabbar. You said, your job is to make sure that your patients live as well as they can for how much time they have left. Can you dig a little bit deeper for me on that in terms of what practically that might mean?
That's also a fantastic question to think about. One of the things I say to patients and their families all the time is the biggest challenge about getting older is accepting that there will be decline no matter what. It's like the pipes in your house. They're not that different from my vessels. There's wear and tear. They don't work as well anymore. And no matter how much you invest into it, sure, it can slow it down a little bit, but there's always going to be breakdown. And I always want to frame it that way to families because I don't want them to feel like they are the ones that are responsible for the decline. They're not, right? I think this is the thing. We blame people for decline happening. And so I say to somebody, look, it's not because you didn't walk enough. It's not because you didn't strength train. This is just part of reality. It's part of the existential existence of being human. And so when we frame it that way, then we can say, look, if we're acknowledging we're all mortal, if we're acknowledging all we're all going to decline, then tell me, what do you want to do with the time that you've got left? What brings you the most joy in life? And if you figure that out, then you can actually make the most of whatever else you have left.
I know people are going to be listening to this and saying, okay, but what is that age? What is the age where those pipes start to decline? Is it is it from when we're 16 years old? Is it from when we're 40? I'm 54. How much decline am I seeing?
That's a great question. And we don't really know what the answer to that is. What I will say is that what we do know is really after the age of 70, in particular, probably even 75 if you're really starting to push it a little bit, is that when you start to lose muscle, you can't physiologically really get it back. It just doesn't happen anymore. And so I often use this analogy of the rubber band that's been sitting in your drawer for 5 years. It looks great, but you take it out and you put a little bit of tension on it and it snaps. So, when we're in her 75, 80, 85, 90, you can look really great. And you should do all the things that you should do to keep yourself physically active. Strength train, 150 minutes of exercise, socialize with people outside of your family 3 times a week. Those are all the kinds of things I say to people. But at the same time, just know that the physiological reality is that your reserve isn't there. So if you get a pneumonia, it's not going to be the same.
That's such a gracious way, not only for individuals to look at their own progress through life, but also their family and their caregivers. Of like, there is an inevitability of this to this.
Yeah.
Let's recognize it so that there's
Yeah.
no shame. How much do you lump this into ageism, Dr. Jabbar?
I don't want people to think that they can't do anything. But I also don't want people to individually blame themselves for what they can and can't do, right? So I'm thinking particularly, for example, of a patient of mine who had a stroke. And in the spot of the brain where she had a stroke, she can no longer walk reliably well. She just can't. Like that's just like it's the brain. That part of the brain's not going to regenerate. She's lost that part of the brain. Now, this patient of mine can't walk that much anymore. What that also means now is, over the course of the last 2 years, she's progressively losing more and more mobility. I can't turn around and say to her, "Get 5,000 steps a day." I can't. But that's kind of what her body needs in order to maintain what she has. So, we had a really tough discussion about saying, "Look, you're gonna have to accept that there's gonna be decline. That at some point you're gonna become bed-bound because this is just the reality of your body."
That's tough.
It's hard.
What do people misunderstand about geriatric medicine?
I think occasionally, and I don't blame people for this at all. People walk in the door and hope that I have the pill that's going to fix something. It's going to fix their memory. It's going to fix their walking. It's going to make their pain go away. I don't have any of those things. We can cushion some things. I can scaffold people a little bit, but I can't make any of that stuff go away. So I think the bigger conversation I have with people is not only just kind of like, what you want to do with your life, what brings you joy, but kind of trying to figure out like what matters the most to you.
Mhm.
What's non-negotiable.
It's so interesting because we're going to transition to talk about dementia and Alzheimer's. It is January and it is Alzheimer's Awareness Month. But something that people have talked to me and my producers, Jess and Carrie, about with this podcast, and I would think, Dr. Jabbar, you come across this too, is isn't it sad? Are you just talking about sad things all the time? How do you deal with the sadness of it?
I think about this in the context of my kids all the time and having these conversations with them and thinking about how you can't separate joy from sadness. You can't. This is like the yin and yang of life. You can't separate the joy from sadness. You can't deal with happiness without some anger or fear or like you can't separate these fears or these emotions apart from each other. So a lot of the things that my kids and I talk about is just kind of living with the feelings and feeling the feelings and that being okay. And that part of the sadness can also be bittersweet
Mm.
because a lot of what I love doing in my clinic is talking to people about where they've been and what they loved doing, right? And you can't have that unless you've lived a full life.
What brought you joy? What brings you joy in life? And how can we still incorporate that into your life, even though there are all kinds of things that you might be declining from? How do we make sure your life is still infused with the things that light you up?
Absolutely. I think about this stuff all the time. So I've said to my husband, I was like, look, the things that are non-negotiable in my life are being able to read and ice cream. Like no word of a lie. Like I said to him, if I'm ever nonverbal, Cherry Garcia 3 times a day. That's it.
You're bringing me joy with that.
Right. Right? Like and I think it's so important to share that with the people we love,
Yes.
to
Yes.
tell them that.
My husband said to me, as long as I can listen to the Blue Jays play,
Yes.
I'm happy. That's what I want.
Totally.
I just want to be able to listen to a baseball game.
Yeah. Oh, yeah. Oh, yeah. I mean, I've even said to my husband, I was like, "If I'm not completely there, just put on repeat the Jose Bautista bat flip. I'll be good. That's it. I can relive that moment forever. That's cool.
Yeah.
Great."
We talk so practically about certain things on this podcast. I love talking about things that might not matter, but actually light up your pleasure center so significantly that have nothing to do with what you're going to put in your will, who your powers of attorney are, who whatever. I need some Cherry Garcia ice cream and I need that Jose Bautista bat flip, please and thank you. Is it fair to say this is a bit of a hard left because I'm giggling now, but,
Right.
is it fair to say that the majority of your patients, of patients who are coming to a geriatrician, are living with some sort of cognitive decline?
Yeah. Yeah. I mean, they are. I mean, think usually it's, a family doctor being like, something's going on, or they just need a second opinion. They often know what's happening, and then they just need a second opinion, somebody to do the full testing. The other thing we don't talk often about is how often cognitive issues happen and how common they are. So the stat that actually kind of state to people is that after the age of 70, 1 in 4 people will develop cognitive issues. After the age of 80, it's 1 in 3. And after the age of 90, it's 1 in 2.
Are all of those cognitive declines dementia?
Not necessarily. So it's a really good point in which for me to kind of even stop to say, people often say Alzheimer's versus dementia, which is which, what's going on. And so the way I often describe it to people is dementia is a big category in which Alzheimer's is one type of dementia, it's the most common one we talk about. And the analogy I give people is think of dog as a big category and all the different types of dogs there are. So in that way, the way I describe dementia is somebody who's got cognitive issues that's affecting their function. When it starts affecting your function, we call it dementia. So, unfortunately, yeah, those numbers pan out. So
Yeah.
after the age of 70, one in four people will eventually have cognitive issues that start to affect their function.
I want to do a little bit of order for people because if they're in this situation, either themselves or somebody they love, and they're looking for a diagnosis, do they need a geriatrician to give a diagnosis of dementia or Alzheimer's, or do they ask a family doctor for a referral to a geriatrician after that diagnosis has happened?
Family doctors can absolutely make the diagnosis. The diagnosis itself is actually not that complicated. Basically, the outline is in an area of cognition that you're having some decline, some evidence of decline, and it's affecting two areas in which you need to be able to do higher orders of activities of living. So, for example, if I'm starting to have short term memory issues and I'm starting to forget my medications and I'm forgetting to pay my bills, bingo, I have a diagnosis of dementia. That's it. So, most family physicians understand and know how to diagnose dementia. Often, family physicians are sending their patients to me or another geriatrician if they need help figuring out kind of dementia is this, because there's so many types of dementia. If there are issues with behaviors or personality changes that are happening, if they need someone to take some time to kind of talk about exactly what the prognosis looks like, what progression looks like, to really dig deep into those, to assess driving, for example, that's a really big one.
I guess I shouldn't be, but like, I'm so curious to you bringing up the driving factor. Can you articulate for us how important that issue is when people are experiencing some dementia?
Oh, driving is like probably the most painful part of me talking about the stuff I do in clinic. Oh my God, I'm covering my eyes here because it's so painful. It's exactly what you've talked about, right? It's all the things around like independence, autonomy, things I can do on my own. It's so much easier to talk about it in a city versus rural areas because at least in a city, I can call a cab, I can, whatever, figure it out. Rurally, if you've got one cab to your town, what do you do? How do you manage? Driving is a tough issue because every single time I am obligated to ask about driving. When somebody comes and talks to me and is there for, does this person have issues with their memory? Does this person have dementia? In every single assessment, I have to ask you, do you drive? And the other challenge is I am legally bound in Ontario to report anybody who I am concerned about.
I'll tell you, the person who took my dad's license away, my dad had vascular dementia as a result of a few strokes. We're not sure how many or when, as vascular dementia is challenging. But the person who took my dad's license away was an ophthalmologist because he went for his eye test and couldn't see any peripheral from his left eye and was legally bound to do that. And I don't think people understand that.
Exactly it. Every physician has that specific obligation. So, for example, I mean, I've certainly had patients in whom I'm like, you can't physically turn. Like, let's say cognitively they're fine, but they've got major issues with their gait. Let's say they can't really like even like I've seen patients who like have to turn their entire torso to look for their like something on their side, and I'm like, you can't check your blind spot. This is not happening. And at that point, I say to them, I'm sorry, I'm legally obligated to report you. And so it is a really hard conversation. It is a really hard conversation to have. Like, it's the worst. I have had a whole bunch of patients of mine, unfortunately, who end up driving to see me in clinic. I do a full assessment, including memory testing and cognitive testing, and I say to them, you can't drive home.
Oh, Dr. Jabbar, I can't imagine.
It's awful. It's absolutely awful. And then you try to find them a taxi chit or something, call family, have a big conversation. Like it's hard. It's really, really hard. So, optimally what's great to be able to do, and I don't always get to do this, but let's say I've got somebody with mild dementia in my office or somebody who I can see is starting to decline, I talk about retiring from driving. I say to everybody, just the way we're declining, our bodies are declining, we're at some point are going to have to retire from driving. We have to think about what is my life going to look like when I retire from driving. In the city, the answer is relatively easy because the pitch I make for people in larger cities is with the amount of money you get from selling your car and not spending it on insurance and gas and maintenance and all that stuff, you spend it on cabs. It's a lot trickier when you live rurally, and I don't have an answer to that. I haven't done rural practice in a long time, but that's the really tricky one. And unless you've got close family around, close friends around, community around, I've certainly heard of some communities, for example, starting to do food deliveries and supply deliveries and those kinds of things for people and start banding around things. It's community that saves us in the end, right?
It's totally community that saves us in the end, and also, I'm so grateful that there are those delivery services and they're all that, but it does not then address the issue of the loneliness epidemic for seniors,
No.
the need to socialize for seniors, all of the things that driving, especially in rural areas, allows for them, so it's very, very tricky.
It's really hard. I mean, I think one of the ways I talk about socialization with families is if you want to maintain good cognition, you need to have social engagement with people outside of your immediate family at least 3 times a week. That's the goal.
I'm gonna go back to that order. So, a GP can diagnose dementia or Alzheimer's. Is it automatic for somebody who is diagnosed with Alzheimer's or dementia to then have a referral to a geriatrician?
Not necessarily. There are some family physicians who feel very comfortable depending on what their patient population is and what the kind of people that they see in their clinic who feel really comfortable dealing with Alzheimer's and dementia. There are also some family physicians, a large cohort of them, actually, I don't know exactly how large off the top of my head, who actually have additional training in something called care of the elderly. They do an additional year of training for older adults. I have many colleagues who are in that boat and for whom I'm like, if you need to call me, just call a friend and, answer some quick questions if something feels out of your scope. But other than that, you don't need to see a geriatrician at all.
How would a geriatrician approach treatment of somebody with dementia and Alzheimer's that might be different than a GP?
That's a great question as well. Again, depends on sort of their scope and comfort of practice. That probably will change within the next couple of years. And so what I mean by that, I know, probably even within the next year or so.
Tell me everything.
I will, yeah. Up until now, the only set of medications that we've really had available to us for dementia are a group of medications called memory enhancers. You may have heard of medications such as donepezil, otherwise known as the brand name Aricept, before. Those are the things that we really had. And there's lots of family physicians that I know who are very comfortable in starting those medications and maintaining those medications. The thing that has now changed is there is now a new group of medications called disease modifying therapies. They're specifically designed to target this protein that accumulates in the brain called beta amyloid. Canada is one of the last countries now to approve these medications. They've been in the US for now probably close to at least 5 years, I think. The medication that was approved by Health Canada is a medication called lecanemab. We're expecting another couple of those medications in the same family to be released within the next couple of months even. Now, things are going to change pretty rapidly in the next year because now we've got lots of hospital organizations trying to figure out how do we actually administer this medication because unfortunately these medications right now are not simple pills. They're actually infusions. You have to go and have an IV inserted and have the medication infused depending on the medication it is every 2 to 4 weeks for about an hour.
Who has prescribed this medication, Dr. Jabbar? Is it people that are in early stages of dementia or Alzheimer's? At what point do these medications impact somebody living with this disease?
That's a great question. These groups of medications are specifically for people with mild Alzheimer's dementia, so very specifically Alzheimer's dementia, or mild cognitive impairment, meaning they've got short term memory issues that is not impacting their function.
So I am going to point out here what we learned from Kathy Barrick and what you are suggesting as well. And people are so afraid of this, but early detection is crucial in terms of treatment. Can you re-articulate that, please, so people are not afraid of this?
Absolutely. I will say one of the things that's so interesting about this group of medications, the caveat I will add is it's going to take a while to roll it out. And unfortunately, access is going to end up becoming an issue. It's going to be really accessible, probably more specifically to those who have private insurance, because out of pocket, it's going to cost close to $30,000 a year right now. We're really hoping that when there are different ways in which they're going to be administered, like as a sort of under the skin injection, we call it a subcutaneous injection or an oral pill, that the costs will come down substantially. But for right now, it's going to be close to $30,000 a year. So that's going to be a big issue.
And I'm going to add to that cost. What I'm hearing from you is there's an infrastructure issue in terms of what it's going to require for people to actually access the drug because it requires an IV. It's not a simple pill.
And it also requires people to get lots of MRIs. And so let me explain that part of it as well. This is the first time in my career that there's actually a medication or a group of medications now available that slows down the disease. It's 30% slowing close to. It's substantial. It really is. It's meaningfully slows down the disease. It's not a cure. I'm still going to go back to what I was saying in the beginning. We have to embrace decline. But it does buy people time, especially in the mild duration of the disease. So it may be really meaningful for people, the 30% slowing.
It also buys people time with the disease. I am just going to say it that for the average person, terrifies them to the point of not wanting to find out if they are affected by it.
100%. And this is the thing, it's like you need to find out early because if these medications are accessible to you, it gives you time to actually do the things that you want that are meaningful in life, right? To squeeze that extra trip in, to have some extra time with your grandkids if you have them, to do the things that you want to do. It gives you time to do that, to plan, to figure out what you want to do with that precious time that you have left. It does. The sad caveat of it is among about 3% of people who use this medication, all of the trials have showed that they get symptomatic swelling of the brain, meaning they get headaches, confusion, sometimes worse cognitive decline as a result of it. 3%. Of those 3%, when you stop the medication, most people resolve. Those symptoms go away. Because of the risk of swelling, the systems issue is that people will also require very frequent MRIs in the first 6 months. And I think right now it's at month 1, month 2, month 3, and month 6. So it puts a lot more pressure on the system as well. Not only are you thinking and burden on families and patients themselves to have more visits. I can't tell you how many times I've got patients complaining, I can't deal with another doctor. I can't. Now you gotta deal with a lot more of them. So it's not all, it's not all roses and sunshine. It means infusions every 2 to 4 weeks potentially, and then, MRIs.
Right, so there's progress, but progress with a large asterisk.
Exactly. And these medications will largely be at this point, certainly for me as a geriatrician, I'll be the ones prescribing.
How do you deal with people who can't afford medication, Dr. Jabbar?
In Ontario, we're really lucky because after the age of 65, most of it's covered. The vast majority of it is, which makes my life really easy. Like I can't imagine the life of family physicians when you're dealing with people less who are much younger than 65 and can't afford it. Certainly I've had some people being like, I'm afraid of what's going to happen if I lose my job because then I lose my insurance, et cetera, et cetera. That part is really hard. It is extremely hard. So I always think about whenever people talk about implementing a national pharmacare program, this is why you get better buying power of your medications. It drives costs down for everybody, not just the people who don't have private insurance. Like it's just it's a big win for everybody. But fortunately, like I said in Ontario, 65 over we're covered.
Maybe this is an impossible question to answer, but I'm gonna ask it anyway. Why is Alzheimer's so complex?
Medically, we just know so little about the brain. We have all sorts of theories about how these proteins interact and fold and, stick around and create plaques, all sorts of stuff. But that just touches, Alzheimer's and maybe even just a sliver of Alzheimer's. There's so much we just don't know about the brain and how everything functions. That makes it really complex. Socially, what makes it complex is the way in which we live our lives so separate from each other. I mean, I think about this in the context of when I was raising when my kids were much younger, and how a friend of mine would say, we were really never meant to raise kids like this.
What is the like this?
Like, just alone in the middle of the night, awake, being like, I'm gonna die. I have no sleep. I've been awake for 4 hours, cluster feeding this child. You know, I think always about how my grandmother in India, my grandparents were quite affluent in India. They were very fortunate. My grandmother had 5 children. My mother is 4 of 5. My grandmother, for fun, went to start doing her bachelor's of commerce when my mother was 2 weeks old. 'Cause she could. Because they lived in a big extended family. Everybody lived in the same house. She could pass my mother off to her sister-in-law, who just had a baby 7 days before, who would breastfeed my mother, and my grandmother would go off to school for fun.
Community.
Community! And people are aging in the same circumstances as well, right? So you've got all of this stuff, all of these people, all of these hands, multi-generational, et cetera, et cetera, et cetera. That's why it was easier. Not easier, but, just, everybody got to hold the load. You don't get to do that. That's the complexity here now.
The possibilities are so much greater with more hands on deck.
It is, and it's fundamentally the way in which our society is constructed. I remember reading an Associated Press article a year ago about how the epidemic, if you wanna call it an epidemic, if older people living alone has now also arrived in India. Nursing homes are a booming business now. Why? Because you need to now have 2 income earning people in a household. Nobody lives multi-generationally anymore in India. People are starting to not do that anymore there as well. So that's happening there as well. It's not just a cultural thing, it's the way in which our societies are set up. So if we don't have a ways of having people have flexibility in order to be able to share the load in a community kind of way, that's what happens.
I want to make sure we're clear about there are some things that families cannot do when somebody requires medical help. Sometimes, especially with Alzheimer's and dementia, there are personality changes, there are safety factors, and making sure your loved one is safe has to be the North Star. And that can require placing that person in a retirement community that has graduated care or a nursing home. Fair?
You hit the nail on the head. Absolutely. I have so many family members coming to me saying, Dr. Jabbar, my mom said she never wanted to be in a nursing home. And my response back to them is, your mother didn't know she was going to be 95 years old with severe dementia, unable to walk, striking at people when she's being changed, and needing continence care all the time. The other frame of it I think about is that if you look at the life expectancy back in the 1960s, right? Life expectancy there was like 68 to 70. That was it. Our life expectancy now is 82. Our life expectancy in 2040 is supposed to be close to 90. The fastest growing age cohort in Canada is 100 plus. And so the thing that I think about there is, so for example, the 100-year-olds that I end up seeing are the people who had kids in their 20s. Their kids are in their 80s. I can't expect their 80-year-old kid to be providing care to their parent. That's bananas.
And I'm going to suggest another demographic of, people who are, so I'm 54. I have lots of friends who had kids in their 40s. So they have kids who are, double digits, but like tweens. And they have parents who are in their 80s. I was my mom's second. She had me at 26. She's 81. So you cannot expect yourself to also be rearing your children and taking care of your senior parent under the same roof. There are just certain things that our demographics have changed and affected so significantly.
We can't do this alone. And even by that, what I mean is we can't be expected to do this as like immediate family members alone. Like it has to be across multiple families, across neighborhoods, across communities. It has to be a social project.
So, how do you involve families? When you have a patient that comes in, are you like crossing your fingers that they're bringing a spouse, a child, a niece, a nephew, somebody with them? Is that what you're looking for?
Our admin, when they call and say, you've got an appointment, and then they usually also call a family member and say, we need a family member to come in with. Always. So we expect family to be there.
So, when somebody does get a diagnosis of dementia, of Alzheimer's, what should caregivers expect? What do you tell that family member that comes in with that new patient about what lies ahead?
I start the conversation usually by saying that I've probably feels like I've thrown a grenade at them. That they're probably going to walk out of here with about 20% of what I've said stuck in their head. And I know that full well, and that's fine. It's going to be as clear as mud when you leave the room. And so what I always do is I connect people with the Alzheimer's Society. And I say to them, these folks are going to be your lifeline for information of what's coming. And then I have a general conversation with families about saying, when I say, your loved one has moderately severe Alzheimer's dementia, that's gobbledygook. That means nothing. So I always give families a sheet of paper that says the global deterioration scale. They can look it up on Google. I say to them, if none of this makes sense, look it up when your brain is not racing. Look up the global deterioration scale on Google with the words Alzheimer's Society. And there's this beautiful sheet that the Alzheimer's Society has produced that'll come up. And it's a scale that goes from 1 to 7. 1 being no dementia at all, 7 being end stage dementia. And then I say to them, when I say your parent or your loved one is a moderately severe, they're 5 out of 7.
So, you place them in that scale.
Yeah, it just means something different when I say to them where they are. And then the thing I say to families is when you go home, when your brain is not racing, you get a chance to read what a 5 out of 7 looks like. But then you also get to read what a 6 out of 7 looks like and a 7 out of 7 looks like. Because I say to them also, the progression's going to happen. Inevitably, they also ask me, Dr. Jabbar, what can we do to slow down the disease? And I say, we don't know really if you can slow down the disease. And then I kind of talk to them about the medication stuff, et cetera, et cetera. But I say to them, this is not in your hands. And doing an extra Sudoku or crossword is not going to slow down the disease. You don't need to put the pressure on mom or dad or your wife or your spouse or whoever to do that extra work if it's not bringing them joy. We want them to be active. We want them to go to day programs. We want them to be engaged if it makes them happy. But just know that you're not going to be the reason that they're going to decline. And that's a hard thing to hear from people.
Yeah. Also, in the long run, you've got to believe that it removes some of that pressure of what can I, what should I, what must I be doing?
Totally. I hope so. I really do. Because that's the hardest part. That's the and I say to people all the time, you're not here because of something you did or didn't do. This is your brain. This is just we don't exactly know why you got it. Probably most of it is age, right? I mean, especially if, like I said, if you're 85, you had a 1 in 3 chance of developing it anyway.
And you're still living at 85.
You are. Yeah. Yeah.
Like, We have to put some of this into perspective. You've touched on it in terms of life expectancy and how that has changed. You've touched on it in terms of the actual numbers. You've touched on it in terms of, finding joy in life. Like the irrefutable fact that there is decline as we age. We are living longer.
We are. We are.
That is going to expose our brains and our pipes, as you said earlier, to different things. I'm interested, Dr. Jabbar, about communication tools, especially in the early stages when people can be when it can be frustrating for people. Do you give communication skills that help with distress?
It depends on what stage of Alzheimer's they are and what that distress looks like. So it's interesting. I'll kind of give you an example. At the really end stages or the more severe stages, particularly when some of our patients are admitted to our seniors internal medicine unit, we try to avoid medications as best as we can because a lot of this is just like it's just distress. And so one of the things our staff have been really good at is having baby dolls around. We have so many patients we've had where they're like, you give them a baby doll and a bottle and a blanket, and they just want to take care of that baby, and all of a sudden they're super calm. It's amazing to see it.
That's so beautiful.
It's amazing. It really is.
You just brought up something that I'm not familiar with and we haven't talked about yet. When they're admitted to seniors internal medicine, what's that?
Well, so I'm very fortunate. I work in a hospital where we actually have an internal medicine unit. So it's a unit where people are coming in with sort of critically ill issues. Like, so for example, somebody with a pneumonia. We're really fortunate at the hospital that I work at. We actually have an internal medicine unit that's just for seniors, for older adults. So we have staff that are very specialized in particularly because a large proportion of our patients have dementia.
Mhm.
They're really, really skilled at working with people with dementia. So, like, we'll have exercise program. We have something called 10 at 10. We have a recreational therapist who's fabulous. Her name is Natalie. She comes and she does like this whole, like, we get all of our patients out into the hallway at 10 o'clock and they all do this whole exercise routine with music on. It's great because we know that for people who have cognitive impairment who are in the hospital, they really decline in the hospital. Hospitals are not good places for older adults. Their mobility actually gets worse in the hospital. They lose a ton of weight in the hospital. They get more confused in the hospital. So we're fortunate where I work specifically that we have this amazing unit that actually helps to orient people and actually get them moving and hopefully not have them decline in the hospital in the same way.
As you said to that family who comes in with their patient, there is going to be decline. This is a disease that is incurable. When do you start to make advanced care plans for somebody living with Alzheimer's?
Yesterday, I say to people, we don't talk about this early enough. Like, we need to, all of us, like, forget even the Alzheimer's stuff. We don't talk enough about end of life. We don't talk enough about what actually makes life meaningful in terms of living. Like, what's the non-negotiables? And then we don't talk enough about the nitty-gritty. Like, the nitty-gritty is almost relatively easier to talk about. Stuff like the funeral plans. Where's my will? Those things are the practical things, absolutely, positively, we should be doing. We should all be talking about those things all the time around, like, just again, the practicals of the will and et cetera, et cetera. The harder stuff is the gray zone stuff. And what I mean by that is, what do I want done to me if I'm really sick and can't communicate what I want done? What if I'm really, really sick and am not cognitively well enough to be able to communicate what I want done to my body? That's a really hard conversation to have with your loved ones. And so I've had these frank conversations with my mom, for example. My mom and I are like, this is the kind of stuff we talk about all the time again. And so she is very clear. She says, if I am declining, I don't want a life in which I'm going to be physically impaired. And if that means my life is going to be shorter, then I don't want medical intervention.
Is that powers of attorney for personal care, Dr. Jabbar?
Yeah, but for personal care and for health. Yeah.
Oh, how do you define quality of life for somebody living with dementia or Alzheimer's?
I ask them. It always is, right? Like, quality of life is different for so many people. Again, like, when I've had conversations with my husband about this, I say to him, if I can't walk around the block, with a walker, that's not quality of life for me. But I've certainly had other patients who are like, look, I don't need to walk. As long as I'm upright and surrounded by my kids and my grandkids, that's quality. But you don't know that until you actually have that conversation with people about it.
What are we getting wrong about dementia and Alzheimer's?
So the thing that we get wrong, I think about this a lot in terms of I know what the decline looks like from dementia and Alzheimer's. Like I know it. I see it. I've seen it with thousands of patients that I've had. And somehow in healthcare in particular, we do such a poor job of telling people what's coming. It's hard to tell people that most people from dementia pass away from aspiration pneumonia, from something going the wrong way into their lungs and causing a pneumonia that they don't survive from. It's really hard to tell people that people from dementia stop eating and drinking and walking, that it's like aging backwards. It's really hard to like really pragmatically think about that stuff. We don't talk about it bluntly enough because if people don't know it's coming when it happens, it really is a huge shock. It's awful.
I've said if I was to rename this podcast, I would rename it None of This is a Surprise.
Yes. Yes. Yes.
So let's talk about it.
The thing I think about all the time is like feeding tubes, for example. It's like the feeding tubes should never happen ever, 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 ever. But how many times do I see them? And it's all because we don't talk enough about what's going to happen.
Why are feeding tubes so cruel?
One of the things I say to people that one of the heartbreaks of the end stages of dementia is people lose their swallowing. But it's not just food and water, it's also our saliva. So there's this perception that, oh, my parent or my loved one needs nutrition, so we should put in a feeding tube either through their nose or through their stomach. It doesn't prevent anything. You still have to manage your saliva. You're still going to aspirate that. It's still going to cause a pneumonia. And then on top of that, you've got a tube. And for someone who's confused and not with it, your initial reaction is always, I want to pull that tube out. Or you're going to be touching the tube and you get an infection.
Let's stop the agitation.
Oh my gosh. The quality of life is so much worse with a tube. It's awful.
I end every episode of this podcast with one question because we're building up this library for people. How can we better support caregivers?
There's not enough home care. There's not enough emotional support. There's not enough prepping people of what's coming. There's not enough. How do you help caregivers keep their own identity outside of their loved one, right? Like what are you going to do after your spouse passes away? How are you going to take care of yourself? I always say to people when I go in for the particular patient of mine with dementia, I'm like, I can't just deal with you. Like, I can't just deal with my patient. I got to deal with the unit, the family, because if the caregiver's not well, the person's not going to be well. And the number of times I've seen the caregiver get extremely sick or pass away, it's awful. Caregivers are missing everything. Every aspect of holistic support that they need at this point, I think we're pretty well failing them miserably right now.
Yep. And how are those caregivers getting that? You brought it up a few times, 3 times socialization outside of their family each week.
They're not. They're not.
I warned you of this when we had our first call, and I've never been more sure of something in my life. You are going to be a regular on the Heart of It All if you will grant us your time and your brain and your incredible, incredible empathy. I could listen to you talk about these things forever and ever, Dr. Jabbar. We're very lucky to have you in this province, and I hope more and more people have access to somebody just like you.
Thank you. I love talking about this stuff. You can't get me to shut up. That's the problem.
I know you're not supposed to pick favorites, but that might be my favorite episode yet. So much of what Dr. Jabbar said is exactly the reason I wanted to start this podcast. She really felt like-minded to me and what we're all about here on this show. Thanks so much for listening to The Heart of It All, brought to you by
capitaldirect.ca.
Thanks also to my friends at 6 of 1 Digital. They are Carrie Hayden and Jess Carroll. They support me week in and week out. Wherever you're listening to this podcast, please do us a favor, rate the podcast, leave a comment, and share this content with somebody who you think would enjoy it. You can also visit us on all our social media channels, Instagram, Facebook, TikTok, YouTube, and we have a website that has all of the information from each and every episode. It is theheartofitall.ca. Thanks so much for listening, and please take care. This week's movie recommendation comes from a person who makes movies that will get you right in the heart. It's from Heather Young. She's from the East Coast of Canada, and the movie is called There, There. Heather made this movie as a memory of her relationship with her grandmother, who she lost to dementia. It is about a caregiver and her patient and the bond that they have. It is called There, There, and I highly recommend it.